In this section, we're going to briefly talk about thermoregulation and periop hypothermia. So what's heat balance and thermoregulation? Body heat is unevenly distributed, as you guys know, with a typical core to peripheral temperature gradient of 2 to 4 degrees Celsius. As with any other neurally mediated physiologic processes, thermoregulation involves afferent thermal sensing, central processing, and efferent responses. Thermoreceptors are distributed throughout the body, like skin, abdomen, thoracic tissue, etc., with impulses in response to hypothermia and hyperthermia transmitted to the central nervous system via the A and C fibers. Central processing, primarily in the hypothalamus, results in voluntary and involuntary efferent responses. Voluntary responses are like wearing a jacket and adjusting the thermostat, or involuntary autonomic reflexes like vasoconstriction, etc. The slope of this efferent response intensity, like how much vasomotor changes you get versus core temperature, defines the gain. And we'll talk more about it in just a bit. In somebody who's not anesthetized, cold-induced autonomic defenses follow a kind of a hierarchical pattern that progresses from vasoconstriction to non-shivering thermogenesis and finally shivering thermogenesis. Vasoconstriction decreases cutaneous blood flow and heat loss, primarily in the fingers and toes. And even though its effects are minimal in adults, non-shivering thermogenesis can double the metabolic heat production in the mitochondria-rich brown fat that's present in neonates and young infants. Shivering thermogenesis results from involuntary skeletal muscle activity that increases metabolic rate and heat production. This threshold for warmth-induced autonomic responses, such as active vasodilation and sweating, is similar. And each gram of evaporated sweat dissipates about 540 calories of heat to the environment. Core temperatures between the first cold-induced, like vasoconstriction, and warmth-induced, like vasodilation, responses define what is called the inner threshold range, or ITR. Temperature within this 0.2 degrees Celsius range don't trigger thermoregulatory defense mechanism, and this ITR of 0.2 degrees Celsius, as you can imagine, is very tight. So what are the effects of anesthesia on thermoregulation? So under general anesthesia, when you give IV drugs like propofol or inhaled anesthetics, they inhibit thermoregulation in a dose-dependent manner. That is, general anesthetics increase the threshold for warmth-induced thermoregulatory responses and decrease the threshold for cold-induced defenses. And accordingly, there's a 20-fold increase in the inner threshold response, and that increases from 0.2 to 4 degrees Celsius. So in somebody who's not anesthetized, a 0.3 degrees Celsius results in a response, but in somebody who's anesthetized, to get the same response, you have to have a 4-degree change. So as a result, you can consider anesthetized patients are poikilothermic over this 4 degrees Celsius range, which renders them susceptible to significant heat loss and hypothermia. What about regional anesthesia? Again, thermoregulatory defense mechanisms are neurally mediated. And when you do a nerve block, this disrupts this neural pathway and interferes with thermoregulation. Same thing, spinal anesthesia inhibits central thermoregulatory control by an amount that depends on the level of the block. So the higher you go, the more this system is affected. And because thermoregulation remains intact above the level that you have your block, increases in the inner threshold response are not as dramatic as those observed during general anesthesia. What are the systemic side effects of periop hypothermia? So let's look at the CNS. Hypothermia can protect the brain from ischemia and traumatic injury. On the other hand, fever can worsen outcome after cerebral ischemia and head trauma. Hypothermia decreases brain activity, and this is as evidenced by what you see with changes in EEG. You see slowing of the waves, and also if you're looking at the somatosensory evoked potential, you get increases in the latency. Mild intra-op hypothermia can also prolong post-op recovery, and this is some effects directly on the brain as well as slowing the metabolism of drugs. What about the cardiovascular problem? So decreased core temperature can slow the intracardiac conduction, predispose the patients to developing lethal cardiac arrhythmias, increase pulmonary vascular resistance as well as systemic vascular resistance, decrease myocardial contractility, decrease cardiac output, induce myocardial ischemia, and interfere with platelet function and coagulation cascade. And this is to the large degree from decreasing production of thrombin. Interestingly, myocardial ischemia is not entirely from the shivering-induced increases in whole body metabolism. That is, other contributory mechanisms include increased myocardial work from the catecholamine-induced increases in SVR, blood pressure, and heart rate. In patients who've been successfully resuscitated after cardiac arrest from VFib, there are a couple of studies that show that therapeutic mild hypothermia can increase the rate of improved neurological outcome and reduce chances of fatal outcome. And keep that in mind, though, there is another study that was published a couple of years ago that shows there is no benefit from mild hypothermia, and they looked at 34 degrees Celsius after cardiac arrest. What about wound infection? So you can imagine decreased cutaneous blood flow impairs regional oxygen delivery, neutrophil function, and delivery of systemic antibiotics to the wound site. So, and the combination of these from the hypothermia-mediated perturbation have been shown to increase the risk of wound infection during hospitalization, and that can increase the risk by 20%. That's pretty significant. Systemic hypothermia can also cause a left shift of the oxyhemoglobin dissociation curve, so oxygen sticks to the hemoglobin more tightly, decrease O2 consumption and CO2 production, slow metabolism of anesthetics, predispose patients to developing citrate toxicity for giving blood. So how do you prevent it? Peri-op hypothermia occurs via several heat loss mechanisms, like redistribution, convection, radiation, conduction, and evaporation. And even though all of these mechanisms are important to some extent, the initial significant drop in core temperature is from the distribution of heat from the core to peripheral tissue. And rapid core to peripheral heat transfer produces hypothermia in pretty much everyone, regardless of the type of anesthesia delivered. Prevention and treatment of hypothermia may be achieved using passive techniques like using blankets, drapes, space blankets, the reflective ones, or using active techniques like forced air convective warmers, the bear hugger or warming blanket, and using the circulating water mattresses that we don't use, the IV fluid warmers, radiant lamps, and airway heating and humidification. Of these techniques, heat conservation is most effectively achieved using forced air convective surface warming or carbon fiber resistive heating blanket.